Good evening, and welcome to a series of critical conversations that we are having on Scroll in partnership with Pi Consulting and Survivors Against TB. My name is Chapal Mehra, and I'm a public health specialist and writer. And today we are going to be talking about the COVID-19 pandemic, but also the comorbidities that interact with it. This has been a long-standing request from many of you to have an actual conversation about some of these comorbidities and how they interact and affect the pandemic. Because as India and the world grapple with this disease, the management of these comorbidities such as cardiovascular disease, diabetes, hypertension have become a significant concern. These concerns are particularly big in countries like India, where a large section of the population is affected by them. And as the COVID-19 epidemic spreads, we need to understand how these interact and work with our physiology. Today, my guest is a well-known medical expert. He's also somebody who believes extensively on issues of access, but also in terms of creating health promotion and health knowledge to help people cope with this pandemic. So today my guest is going to be Dr. Shriram Nene, who's practiced medicine both in India and in the US, and is a cardiovascular surgeon of great repute. He is going to be talking about how we should be managing some of these comorbidities during this pandemic. Dr. Nene, thank you so much for joining us.
Chapal, it's an honor and a pleasure to be here, and I really appreciate you inviting me to the show.
Thank you. Thank you so much. I sort of was in my introduction referring to how these comorbidities, whether it be heart disease, but also hypertension and diabetes and other diseases interact with COVID-19. Now, what we're seeing in the world today is a pandemic which across the world we are clearly not prepared for. Yet in countries like India, where there is extensive cardiovascular disease, India is also considered the diabetes capital of the world. There's extensive hypertension. How do these comorbidities interact with COVID-19? And what should be the way to managing them?
So I think before we begin, there's a little bit of perspective required in that when you look at India as a whole, heart disease is actually the #1 reason for mortality. And 1 out of 4 people who die in India will actually be from heart disease, meaning either coronary events or strokes, which is 80% of that burden in a normal year. And that can be 17 lakh people is the estimate, but we don't know for sure because there's no all mortality registers, as you know. If I compare that to at recent toll, over 140,000 people succumbing to COVID in India. If you look at that versus the US or other places, it's actually low compared to the 1.35 billion people we have. But make no mistake, heart disease is in epidemic proportions. And there's many reasons that's occurring. Now you take that in the current era with COVID, and what's happened is for all elective care, people are scared to go in. And as a result, what we saw in March, April, May, June was that many people were deferring their visits to their cardiologists, not coming into the hospital. And the estimates both in the European journals and in the US journals is that the incidence of sudden cardiac death was increased, but we'll never really know because you don't do autopsies these days with the COVID epidemic and crisis. Now let's talk about something which is more daunting. What is the impact of having comorbidities in the way of heart disease, high blood pressure, diabetes, and kidney disease on the incidence of COVID, and vice versa? If you get COVID, what happens to that? A couple of very interesting points. The first is if the independent predictors of mortality, meaning the risks of death, are much higher with people with cardiac disease, high blood pressure, diabetes, and chronic kidney disease, as well as a few other illnesses. And so what they found is when they looked at mortality and compared it to what comorbid conditions they had, there was a higher proportion of patients with these comorbid conditions. So you're at increased risk of getting it. You're at increased risk of potentially succumbing to it. And obviously age is another factor which is involved. The real question is this, that if you develop an acute episode of coronary artery blockage or a stroke, there's no question in my mind what you need to be doing. Besides the usual things, aspirin, all the other stuff, you need to be getting to the hospital as quickly as you can. Most of the cases in the US measured it in door to balloon time, right? In other words, if that was 30 minutes from the time they hit your hospital to the catheterization suite and then either intervention or OR, your mortality went down. Well, in India, it's rickshaw to door, door to balloon. But in this particular era, it's more an issue of COVID blocking people from going in. So then to answer your question, the risk is significantly higher in patients who have comorbid conditions. Added to that, the risk is higher of having issues with the actual disease itself. So my suggestion is this, that if you do have acute symptoms, you need to go in. There's no question in my mind that you're best served. Wear a mask, call ahead. There's the 108 system in most of the cities where you can get an ambulance or get someone there. Probably the quickest way is to hop in your car, get a taxi or a rickshaw, and head to the closest hospital, which has cardiac care and other units, and be evaluated at least. Now, the other question is, are the beds all full? Because this is an issue that the US is facing right now. And as a result of that, can they not take care of the patients with heart disease and other things? And the answer is perhaps in the US. In India, I'm not aware of that now. I think India has done a good job for various reasons. I think we're a younger population, so you would expect fewer people to die from COVID. In addition to that, we may have some cross-reaction with BCG and with other things. But does that pretty much answer your question in terms of the comorbidities adding to your risk of COVID?
It does. Then I'm going to ask you a follow-up question because you brought up a lot of points which are particularly relevant to our audience. But before I ask you that question, let me say to our audience that we are taking live questions. So you can ask us and Dr. Nene any question you want, either on Facebook or on Twitter or on an Insta where all of this is being streamed live. Please go ahead and ask us and we will try and get Dr. Nene to answer that question. Now, this is what you said about what we should be doing. But the truth of the matter is that the population as we know it is highly frightened. There's a lot of panic. There's a lot of anxiety. We don't know enough about COVID-19. At least we know a little bit better than we started 9 months ago. But the lack of public awareness and understanding around this. So like you were saying, we know that people are delaying any kind of elective procedure if they can. They are delaying seeking medical advice. They're often very scared of changing regimens that they are on. And not everything is a crisis in the sense of you may be having a stroke or you may be having a mild episode, but some of this is about management of these comorbidities. How do these people manage their comorbidities? Because India has a huge burden and some of these comorbidities work with each other.
So these are great points. And to be honest with you, this is like the journey to the moon. This has accelerated it. And many of these issues were critical even before the crisis. And my group and my team is working on moving the pendulum to prevention, early recognition, and early treatment. It doesn't mean the number of cases go down. It just means that India doesn't become a natural history study in seeing stuff late. To your points, what we need to focus on is, how do we get the information to the patients? How do we help them by telemedicine and other means for routine follow-ups? And how do we monitor them in real time with feedback loops? And so to answer that question, I think you would agree that telemedicine has come of its own to some degree, with doctors and medical associations and governments accepting it as a feasible means of taking care of chronic medical issues and routine things. I think at best it's a means for triage, because as a doctor who intervened or operated on people, you had to examine the patient ultimately. But in the cases where you had to do follow-up, or there was a borderline call where they had to come in or not come in and they had chronic disease, I think it could be an excellent means. Added to that, if we could add a level of automated devices or other things, and then are now coming out with automatic blood pressure cuffs, which can give you a reading, as well as SAT monitors and this and that. For the chronic medical patients, we might be able to build in a layer of safety and security where we get a dashboard. And that's what we're advocating, that, we can help these. Ultimately, look, there's no reason to panic. We're all in this together. And what needs to happen is we need to join hands. And as groups and communities, we need to come together to support each other now and forever. And I think if nothing else in this pandemic, one of the silver linings is it's brought families and buildings and groups of people together in a way that's unprecedented. I think we're all looking out for each other. And I can tell you many stories. Most of all, our healthcare workers on the front line. I've talked to many of my peers, and they're real heroes. Heroes without root uniforms, I call them, but people who have dedicated their hearts and their well-being and the well-being of their family and taking risks for everyone out there. So there's a couple of points to make for you. The first is, for chronic stuff, if you're being monitored, keep a journal, right? Take your blood pressures, take your heart rates, and record when you're taking your medicines. Take a shot on WhatsApp, a picture, and send it to your doctor and say, look, this is how it's being managed. Or if you have diabetes, take a picture of your sugars and let the doctor know, right? And one of the bigger problems in India is that doctors don't have the infrastructure they need. Honestly, there's 1.35 billion patients and 1.6 to 1.8 million doctors, of which only 1 million are allopathic, and only 2% of the allopathic ever make it out into the 70% of India that's a rural zone, right? So there's a lot of patients who are underserved, and I think telemedicine and these types of things may allow us to leapfrog some of these problems and at least triage people to get them in early. And we've been a part of many projects which create low-cost, high-impact technology as well as other things in this country and try to change it. But most of all, look, I want to say to people, don't worry. We will all get through this together. The main thing, which I'm sure you've seen, but what we're doing is trying to answer questions and raise awareness and, move to the point where people have access 24/7, 365 in one way or another to evidence-based international health standards. We're not there yet, right? We're not there globally, not just in India. In India, when you spend only 4% of people pay taxes, and only 4% of the total revenue GDP is spent on healthcare, of which 66 or 2/3 of that is private self-pay, then you have to say, look, we do an awfully good job with very little, right? Versus the US, which is 17% of the GDP, right? And I can say the mortality here is much lower comparatively. So I think, the healthcare workers, the politicians, everyone has done a fairly good job in a very desperate situation. For the people at home who are watching, here's my advice. Read, listen, do everything, and ask the right questions. The headlines are scary right now because they go from preprint servers and they aren't always peer reviewed. I want you to connect with your doctors and your healthcare providers, and I want them to be your shepherds because they know you best. And I'll help you, and Chapal will help you in trying to disseminate good quality peer-reviewed information so that we can hopefully, close the gap. And then eventually, hopefully, we'll have access for everyone. That's my goal.
I wanted to ask you, because there are two issues that you've alluded to here in your response, both of which are very relevant today. The fact that there is a lack of public awareness and public understanding, not just around this disease, but around all the other diseases that are interacting with it. And in a sense, every single disease is interacting with this pandemic, right? Because we are looking at people who have to be on chronic medication, have to be constantly, their health status has to be reviewed. They may be on the brink of of a critical episode, we are not aware at this point. And like you said, there isn't enough data, there isn't enough recording that we can actually analyze it. There are three things that I want you to reflect on. The first one is the issue of health promotion and health awareness. Do you think we should be strengthening this in a way that people can self-manage and self-control in a sense? Because we have a shortage of health staff. We have a shortage of health infrastructure. It's not going to change tomorrow. Should that be a focus area for comorbidities, but also chronic diseases at this point?
You hit the nail on the head. I think that, I'm a fan of the superheroes and science fiction, but what we need to do is give people a bat utility belt. And what we need to do is empower them to take care of themselves. And we act as co-conspirators on the journey of life, helping them and acting as their healthcare expert in their pocket 24/7, 365 from the cradle to the grave. And you couldn't have put it better, because in my estimation, I think every single person is different. Your genes, your past medical history, your social history, your culture, your socioeconomic background, even where you live is different. And so your life is very different than mine, than his or hers. And we need to walk in their shoes to understand it. One solution should not fit all, but what we need to do is educate people on the commonalities. What is common between different disease processes, so that they understand what are the symptoms, what are the risk factors, what are the things we need to reflect on that are pertinent, and then how can I prevent this, and how can I attend to this in adequate time so that I don't have a complication. And honestly, it doesn't have to be scary. In fact, one of the projects we're working on is creating entertaining and educational media on the major channels, Netflix, all of that, which will entertain and educate people and never let them forget. Whether it's heart disease or diabetes or hypertension, you'll see it where you can relate to it, right? And in doing that, I think what we'll do is make people more aware of their situation. And I think that's the first step to doing that. And whether it's for any age group, any shareholder, you talk about the elderly, and in India, the interesting part is only 6% of the population is over 60. The majority, 2/3, is below 35. And so we're a very young nation, which really, really, really makes it important right now to put the subsystems in place, because we're going from an agrarian to an industrialized society. And we will see the same non-communicable diseases as the West. And it's already progressed to that point in the last 20 years. And so what we need to do is educate these guys to be aware of what will cause them harm, how to prevent it, and what to do, and then give them the means, meaning the access to evidence-based international standards and the feedback loops that they need to take care of themselves. And I think if we do that together, you're going to see a much better standard of health throughout.
I mean, I want to also take a few questions. And one of the questions that has been asked of us currently is that politicians and bureaucrats have done enough. But I want to, this is a particularly medical query by Ashish Nangia, who is a senior, 81 years old, and he's saying that he has been on and off. He's had an on and off. His father has had an on and off breathing problem, and he's on breathing medication, and still, what can he do? He's scared to the hospital, go to the hospital. This is very typical query, isn't it, Dr. Nene? I hear of these almost on a daily basis, where somebody's saying, I'm having breathing trouble. I think I'm having some kind of chronic disease related issue, but I'm so scared to go to the hospital. What do we say?
So I would say in the 9 months since we started this journey, it's now December, right? We locked down in March. And I would say we've gotten much better at treating disease. There are vaccines on the horizon. But for this gentleman, while I won't give specific medical advice because I've not seen or examined the patient, my advice would be that we need to get him in to be triaged and to be evaluated. And if that means that there's a couple of layers depending on where he lives, I would say we need to have him call them and say, look, what is the most efficient way to be assessed? Perhaps they can send someone fully, in PPE and whatnot, because the problem is in an 81-year-old, he's absolutely right that they're at the highest risk of morbidity and mortality from COVID. But let's say he wears a mask, let's say he wears a face shield, and let's say he goes to a very, very well orchestrated clinic. And to be honest with you, all my peers that I've gone to, they are checking temperatures, they're having mouth gargle, they insist on people wearing masks. Their people are all in PPEs. Every single time they see a patient, they sanitize the rooms. It's very expensive, I will tell you that. But at the same time, it's a mandate, right? You don't have a choice. But I would say there are clinics which are doing that. And what's interesting in this is early on, a lot of the clinics had to close down because they didn't have the means to get all these PPEs and all these other things. I think if there's any issue, depending on where they live, go to the nearest hospital. Because what I don't want to see is that poor 81-year-old gentleman succumbing to something which was, treatable, and for fear, right? Go in with a mask, right? Go in with hand sanitizer and go in with full questions asked, right? And you can also, nowadays, everyone has phones, check on the internet, call the hospital, call people and ask them, is this a safe facility? Have they done everything? And, it's a very interesting situation because a lot of people don't have the means and will end up going to places because they have no choice, right? There's not a lot of medical insurance going on, probably less than 10% of the overall population. And so his question is a real one, right? But my thing is, you have to decide what the risks and the benefits are of anything. And if he is having shortness of breath and he has a heart history, I don't think there's any question in my mind, given his age, because I would say to you that the heart disease will get to him first before any COVID does. And so I think the risk is higher from the heart disease than it is from the COVID. So my advice would be that if you're worried about him, go in, wear a mask, take hand sanitizer, call ahead so that they have all of the other formalities covered, and, go from there. But, the heart disease will hurt you more than the COVID potentially. And that's why I say that don't take it for granted, particularly if you have acute symptoms like chest pain, chest pressure, shortness of breath, radiating, or chest pain radiating to your arm, or even unusual digestion problems in diabetics, which you think may be a atypical chest pain or something like that. If there's any issue whatsoever, it's not impossible to get an EKG and some troponins and get evaluated, because the only way to prevent mortality is by diagnosing it early and treating it. And there are good treatments.
Yeah. Thanks so much. And I think I want to underscore what Dr. Nene was saying is that don't put off any kind of treatment or seeking medical advice. That is critical. We're getting a couple more questions, but one of the questions being asked by Tonya Omar is why and how are sudden deaths due to heart failure among COVID patients being reported? Is that true? What is the interaction? Because that is something that everybody is worried about. And is that true?
Yeah, by definition, sudden cardiac death is usually by an arrhythmia, or which can happen from a heart attack, right? And so it can happen from other reasons too, if you have a abnormal pathway in conduction or whatnot. Heart failure, by comparison, is something you get after a massive heart attack or from structural abnormalities in the heart. And it's usually over a longer period of time, although it can be shorter if you have a valve leaflet rupture or whatnot. So we have to be careful in defining the terms so people understand. Now, the next part of that question is it being underreported? Well, the truth of the matter is we have no reporting system in many parts of India which is cohesive and consistent. And so we don't have an all-cause mortality in India, interestingly enough. And I would say that COVID may actually be something which will galvanize all the hospitals into producing that. Because two things I'm seeing change. One is we can create a dashboard of available beds using GPS telemetry and other things, and also a dashboard of available staff. And that'll be very powerful later in other disease processes, not just in COVID. How this came up is we needed to know how many beds were available in Mumbai and whatnot. And so I was working with various organizations, and we were trying to help them kind of design custom dashboards so that we knew where to divert ambulances, this, that, and the other. Well, look, long term, that has to be there. You need to know how many minutes and how many doctors and how many ORs and how many beds are available. So that's one thing. The second part of it is from heart failure, when someone is compromised to begin with and they get COVID, right? There's two phases to the disease as we understand it. The first is a viral disease, which leads to rapid proliferation of the mRNA. And then from that, you get an inflammatory disease, which is mitigated by the immune system, and you get what's called a cytokine storm. In patients who have poor blood supply to begin with, this cytokine storm and adrenergic overflow can lead to a supply-demand mismatch. What does that mean? You have limited supply of blood flow to the heart in patients who have blocked arteries. And in a case where you get high fevers, high temperature, and your heart's beating very, very fast, and you're very sick and you have decreased blood pressure, you get even decreased blood flow to the heart muscle, and it can result in a massive cardiac arrest, right? And the other second part of that is in many patients, you can get a pneumonia from COVID, and that can increase the work of the heart. And so in patients who are compromised, they end up having a much harder time of it, and their mortality is increased. The last thing I was going to say, and I didn't cover it before, is they looked at the mortality in the US for non-elective surgery. So elective surgery has gone down dramatically. In some cases with things like orthopedics and all that, it's down to less than 30% of their norm, right? But in non-elective surgery and non-cardiac elective surgery, the morbidity and mortality has increased by 14-fold in patients who already have COVID. And the interesting part in the studies which we went over is that many times, in almost 40% of the cases, the patients didn't know they had COVID when they came in. In other words, they were infected and they were tested at the time of the OR, and they only found out a day or two later. So what it suggests is that it clearly has an effect. But to be honest, again, it's a benefit to risk ratio, that if you're having a massive heart attack at home, you can't stay there. You have to go in and you get diagnosed and treated. In the case of an appendix or a bowel rupture or a gallbladder which needs to be operated on, you also need to go in. In some cases, you can temporize with antibiotics or with drainage or other things. In other cases, you can't. But I would say the least non-invasive way, or rather the least invasive way to intervene would be the best if they show symptoms of COVID. If they don't and they're clear with the test and all that, and you need to operate, then you do it, right?
I'm sort of going to ask you a related question. I think a lot of people are, we're getting a lot more questions, and I'm going to start asking you some of those. But before I start asking you, I just want to take a small point from what you were saying, which was about access. And I think both in India and in the US, where you have practiced, access remains a little bit of an issue. This pandemic is a crisis, but it is also an opportunity to rethink and reimagine the way health is administered, the way our well-being is being construed. Now, what would be the top 2 or 3 things that you think countries like India need to prioritize? You've mentioned health promotion, you've mentioned investment in surveillance, but your top 3 areas, because I think that's very critical as an important thing to consider in comparative healthcare.
So what's abundantly clear in the things we've looked at is that we don't have enough, and it's not just in India, it's globally, but we don't have enough physicians, we don't have enough hospitals, we don't have enough clinics to take care of all of the patients, right? And the only way we can change how the outcomes are is by moving towards preventing, early recognizing, and early treating disease. And what that means is no matter which disease you are mentioning, we have to number one, raise the awareness, and number two, ensure a triage process with access to higher levels of care as needed. And if we do that and start teaching people about their health, creating dashboards and creating means to get to care, and I'm saying even in the villages, we're deploying stuff and trying to initiate conversations. If we can speak to them from the heart and say, look, it's not something you have to worry about. Health is something which you endure. And I would say in India, it's very clear to me, health and education and food are three things which we champion. I mean, making sure no one goes hungry, making sure that people get an education, and making sure that healthcare is of the highest standard and accessible by all. If we attack those three things, I assure you it looks like India will be in the top 5 economies by 2050. We may be there anyway. But the other thing which I want to say is that it's not just about where you're sitting economically. It's the happiness equation. And it's about a beautiful culture that's 4,000 years old, which isn't one India. It's 29 Indias, 7 union territories, and numerous religions, numerous languages, and numerous cultures. How do you bring that all together, right? And so that's the interesting part of the puzzle. And, we have a vast amount of knowledge here for other types of medicine, which have to be studied. The other thing is, and we'll touch on it later, but research and the public-private partnership don't exist as I know it. And I came from some premier research institutions in the US, and here they're just not funded. So I think if we focus on prevention, early recognition, early treatment, and then give people a higher level of awareness. I mean, even simple things, right? Like hand washing. Why, where, how, when. And we're doing some of that on the YouTube channel, not just for hand washing, obviously, but for all the topics under the belt. But the idea is that how do you get people to come together and learn what's important? And not because someone's forcing them to, but just so they're aware of why, right? And treat them like human beings and give them the ability to have the power to take care of themselves. How do we do that? That's the question.
I mean, we're getting a few more questions, but one of the things that has come up through discussion that we initiated is, since you touched on it, what is the role of the private sector? Because in India, typically, the private sector is where a lot of people seek care. We know that it is, but at the same time, it's highly expensive. And often the quality of care is very indeterminate in the sense that in some places it's very good, it's very reliable. In some places it may be moderate, or in some places it may not be reliable at all. How do you think the private sector needs to work in health, and how do you think the government and private sector need to partner? Because, for something like the disease that you work in, whether it's heart disease, it's hypertension, or it's diabetes, a lot of it is really getting managed in the private sector. And so how do we do that?
Yeah, excellent points. To be honest with you, it has to be a public-private partnership, because we don't, as I said before, only 4% of India pays taxes, right? And only 4% of our GDP goes towards healthcare, of which only about 1 to 1.5 is spent from the public coffers, which there aren't substantial amounts. And so I don't foresee a near future where the public mechanism can handle the numbers of patients. What I think needs to happen, though, is that we have to have evidence-based international standards for everyone. And what that means is that, for certain disease processes, there's pathways and protocols. And you can be measured by that. In the US, as a heart surgeon, I was a member of the American Board of Surgeons, American Board of Thoracic Surgeons, and a fellow in the American College of Surgeons, as well as a fellow in the Thoracic Board, or Thoracic Surgeons. And we were measured using the databases to see how our performance compared to everyone else. And in some states, like New York, for instance, they would report that to the public. Now imagine if you had a feedback loop where the outcomes were measured. Now, I'm not suggesting that we're trying to, go on a fact-finding mission. What I'm suggesting, though, is to get best practices in place no matter where you are. And when you do that, the trust in great healthcare comes in. And, in some places you don't have clinics, you don't have those measures in place. What we need to do together is to build the ability to scale, right? And some of that, we're very strong in technology in India, in programming, software, all that. Let's use that. The other thing is we're strong in phones. 4G, we leapfrogged over the initial technology, edge and all that. And in many parts of the country, you do have pretty strong 4G. More importantly, the government has said that 120,000 villages will be a part of broadband and fiber-based internet. And when that happens, people will have access at very low cost. And that's already starting to happen, right? The number of internet users has gone up to over 500 million users. It's close to like 675 million now, right? When I came here in 2011, it was barely 150 million, of which only 50 million were mobile users. Now it's blossomed, right? So I'm saying we can use these technological means to help people to at least triage and to learn about what they need to do to stay healthy. And then for the others who get into issues, we triage them and get them to centers of excellence. And so to answer your question, I think a healthy public-private partnership has to be there. I think that they have to be smart about how they institute things, and we need to engineer standards in place. And then we need to make it affordable. I mean, let's call it what it is. If you can't afford it, very few people will be able to use it, right? And, let's face it, in the US as well as here, medical care can bankrupt you. And so the issue is prevention has to be your first thing. But in some cases, I mean, there's no way to get around it. You have a bad family history or you've been doing things. In other cases, there are habits and other things which you can stop and improve, right? But if you need care, we need to be able to dispense it at a reasonable cost and reasonable time frame to get you through the difficult period in your life.
I mean, I'm sort of wanting to take up a few questions which have come to us live, and I want to say to our audience that if you have any live questions, please do send us. One of the questions that is being asked is, what is the role of research here? Very briefly, if you could touch upon it, how should we be investing in research? You've mentioned centers of excellence, you've mentioned international standards. India produces some of the best doctors in the world, but those standards do not apply everywhere. What do we need to do in research?
It's a great question. So let's talk about layers of research. Basic sciences, right, have to be bolstered. I think we have to invest heavily, and the way we can do that is a combination of using government money and, more importantly, private industry money with a level of transparency that's unprecedented. The second thing, so that's basic sciences research, and I think we also need to be training people to think out of the box and to apply different ways of doing it. Now, the second thing is population-based research. And, to be honest with you, this has been a huge controversial issue because drug companies have come in the past and had some questionable practices. I'm advocating something differently. I say that the patient own their data and they give permission to the government and other people anonymously to, look at that data. If you do that, our volumes are so vast. Take a heart disease, for instance. We have such a large number of patients. We could quickly determine as a nation what drugs work, what drugs don't work, what policies work, what preventative measures work. Similarly, in diabetes, we could quickly figure it out. We could advance the practice of medicine by years by looking at this data and the way it comes in. And the way we do that is register people in national pools and protect their data very, very closely, where they own it. They actually are the owners of that in either a blockchain or other type of health stack. And the idea is then to work with the data that we get from that. And we have 1.35 billion people. To power studies and show significance, it would be a matter of just creating AI and other things and getting it done. So I think my host has dropped off. But anyway, that's what I think. So the role of research is critical, not just in clinical studies, but also in basic sciences if we're going to move forward. I think the other thing which would be interesting to research is some of our practices from Ayush, because my suspicion is we're going to be able to identify medicines and procedures which actually have significant benefit and have been used for thousands of years and won't be controversial if you can prove it, right? But no one's really spent the time, because the fact is there's, perhaps no financial gain or other things, but we could add that to the armamentarium. I'll just wait for my host. I hope you guys are doing well on this Saturday evening. The one last thing is, internet, even in the city, is a little dodgy. So please bear with us as we come back on.
I'm so sorry. I'm just going to apologize because I think we've had an internet issue here, and I'm sorry I wasn't away for too long. But I hope, Dr. Nene, that was okay. I apologize to our viewers as well.
No worries at all, and I think I've kept them adequately educated and entertained.
Well, I'm very grateful. Another key question that has come to us is about post-COVID. And I think this is a concern which is skyrocketing among a lot of people with chronic diseases. But I think more broadly about what are the symptoms post-COVID that one needs to watch out for. And in fact, particularly around heart disease, Archana Munshi is asking, saying, post-COVID, what are the symptoms of blood thickening? And I think there are a couple of similar questions that have come up. That post-COVID, do I need to be concerned about other diseases that I've been living with? What is your view on that? If you could talk a little bit about that, that would be very helpful to our viewers.
So it's a great question. We're still finding out new things about this disease. And, for a country which has been afflicted by many epidemics, in 1918, we had a huge epidemic of H1N1 known as the Spanish flu, which actually was worldwide, not just in India, and presumably knocked off a quarter of the population. But anyway, with COVID, there's a couple of take-home points. One is, if you're in the ICU and you're hospitalized, there's certain treatments which actually improve your outcomes. One of them was identified as dexamethasone, which decreases the inflammation. And that's particularly in cases where the inflammatory component and the cytokine storm is prevalent. In addition to that, they are prescribing blood thinners in those patients who are hospitalized. But as a routine in patients who aren't hospitalized, it's not necessarily indicated as a standard class 1 kind of recommendation or that I'm aware of. And honestly, I mean, these things are changing as we get more data. The other interesting thing is some of the late effects in arteries and the vasculitis you get and whatnot. And I think post-COVID, there's a number of things. One is, it's not like the flu. I mean, the flu can knock you down if you've ever had influenza or whatnot. You're sick for 5 days or so, but for 3 weeks, it takes you time to get back to your normal. I don't know if many of you have had the flu before. I'll tell you, in coming to India, I got a true appreciation of some of the tropical diseases. I had dengue when I first came, and then I've had a variety of different other things. The one recommendation I'm going to make is, I think everyone should think about getting a flu shot. I know in India, for some reason, they don't recommend it, but my thing is, it's not very expensive. And if it improves your ability to fight off things, why not? right? It will remove at least the influenza from that. There may be 100 other diseases which you could get from mosquitoes or otherwise, but the bottom line is that's one easy way. Influenza and pneumovax in the elderly in particular, or people with comorbidities, and that'll remove those from the fever differential diagnosis, right? But to answer your questions, I think we'd have to individualize this particular pathway based on what your comorbidities are and how you've reacted to the disease. And it's hard to put it into one sentence as to what I would do, because it really depends on me assessing you or a ICU intensivist assessing you and following you throughout. And so rather than giving you commonplace knowledge so that you run out, and this is one other thing which I'm sure you've noticed, that oftentimes the pharmacists are the only doctors that patients have. They don't actually make it in to see the doctor. I don't want you to do that. I want you, if you're sick, to go and see a physician and be evaluated, right? The pharmacists are great people, don't get me wrong. And, I've had great relationships with them, but I think we work as a team. And so, don't take everything I say or anyone else says as, gospel or the rules. I think what I'm trying to do is to get you to ask the right questions and to get motivated to do something for yourself. And so with answer to this question, I think it's hard to generalize right now, other than the symptomatic care, because it's on a case-by-case basis if you develop a vasculitis or you develop complications as to what to do. But these are the different things which can occur after COVID.
Thanks so much. I want to also ask you a question which has been asked of us, which I think is the question of the year, which is really something about the COVID vaccine. So many candidates, so much excitement, so much anticipation, questions of access, questions of price, questions of distribution. But underlying all that is the fact that we seem to be thinking the vaccine is the cure. You've been practicing medicine for decades. I think it's very important if you could briefly, because we're in the last 10 minutes, discuss and talk about the COVID vaccine and how you think what its role will be.
So the first thing is there's 3 vaccine candidates that have met criteria. The first is from Pfizer and BioNTech. And the companies aren't important, but both these 2 companies and a second company called Moderna have a vaccine which is brand new using mRNA, which is messenger RNA. So normally what they did in the past was to take the virus, put it into eggs, incubate it, and then basically kill the virus or attenuate it, in other words, decrease the virality of it, and then insert something so that you would recognize it, but you wouldn't get that sick and your immune system be kicked up. These new variety of vaccines are very interesting in that they're the first ones which have spliced a small segment of the genome and created an mRNA segment, because this virus, by the way, is an mRNA sequence. It's not a DNA sequence or a tRNA sequence. Why that's important is they've only taken out the spike protein, which is what the immune system looks at, and put it into a lipid layer, which the body takes up and the cells take up. And then what happens is that mRNA, what normally happens is it goes into the cell and it gets transcribed into a protein using the ribosomes, the 50S and the 30S. And then what gets built is the spike protein. The spike protein then shows up on that cell and the immune system sees it and creates an immune response. But because it's only the spike protein and not the rest of the virus, you don't get the bad effects of that. So that's the 2 mRNA sequences. The thing about the Pfizer vaccine is it has to be at very, very low temperatures. I was reading -80 below, and it needs to be sent in special freezer packs and GPS awareness packs. With the Moderna, it's a little more pliable. And both of those had 90+%. I'm thinking 95% efficacy. And remember, it's an interesting thing with vaccines because they give it to 40,000 people, with 20,000 being placebo, 20,000 being the vaccine candidate. And then they look at the number of people who get COVID. And in this case, the number was like 180 or something like that to meet the criteria. And when they looked at the numbers, only 5% of the patients were actually patients who got immunized. The remaining 95% were the placebo arm, meaning that in 95% of those patients, it had protected them. Now, it's always a wonder to me because you can't just expose all these patients to COVID and test it that way. That would not be ethical. But the real question is, how will it perform? So that's the first question. The second one is, do we have late-term allergic or inappropriate reaction results? And the answer is we don't. We only have short-term and mid-term results. So we don't know long-term if there will be side effects, right? Getting to the third vaccine, that's from AstraZeneca and from Oxford. And that's actually a live attenuated vaccine, more like the previous ones. And that one doesn't need to be stored at low temperatures. It's just like 4 degrees below zero. And that's readily dispensable. The other added benefit in India is that the Serum Institute has agreed to produce it at very high levels. And the other interesting thing about this vaccine is that the company AstraZeneca will not take any profit from this. And so it's being offered at a very, very low amount of money. It's like $4 a shot versus $25 a shot for the others. And so that one, the only thing that was kind of interesting about it for everyone's record is that they did a high dose effect, and then they had some samples which were not manufactured properly at half dose. And it turned out that the half dose of 2,300 patients that they immunized actually had a better result. So that to give you guys the procedure, you get immunized first, and then 3 weeks later, you get a second shot in all of these cases. And what happens is with the first immunization, you get a response from the T cells or from the virus, the attenuated virus, causing your own immune system to create a response. And it creates a combination of B and T cell responses. T's will give you the memory so that later you can do it. And then at 3 weeks, you boost it with a second shot, which gives you another response. Now, the one peculiar thing, and I'm pointing these out not because I don't think you should be vaccinated, but we don't know how long this will impart immunity because we haven't looked that far out, right? So it may be 6 months, it may be a year. By all reckoning and by all standard immunological techniques, we think this will be long-term, but we don't know that, right? Now, the real question is, should you get the vaccine? And the answer that I'm going to say is you have to look at the benefits and the risks. If you're in that category of patient who's at very high risk for morbidity or mortality, meaning in India, probably 60 plus, because the median life expectancy in India is 67, but we live in dog's years, right? We live hard lives. And so I would say 60 plus with any other comorbidity like heart disease, hypertension, diabetes, or other things, my view would be that you probably need to get the vaccine because your risk of potentially succumbing to the disease is significantly higher than the baseline. For the younger folks, my own view would be to wait a little while to see that there's no complications. In either case, this is the question of the day, how long will it take? And so and also how much supply do we have? And what's very clear in the case of the Pfizer vaccine is they only have enough for 50 million people total, right? It won't make it to India for some time, in my estimation. In the case of the Moderna vaccine, the same thing. Look, how many people do you have to vaccinate? Now, how many people have had COVID already, probably have immunity, and we could test them to see that, looking at their looking at the antibodies and looking at the other stuff. Number one. Number two, so those people probably don't need to be immunized. Number two, look at the people at highest risk. This is kind of a mitigation strategy where you immunize them first and also immunize your healthcare workers first, because those are the people exposed to people with COVID all the time, right? And then you work your way out. For the person who's 20 years old with no comorbidities, their risk is lower. And I would say, in my estimation, it still doesn't mean you should be scot-free. You should still use masks, social distancing, and preventative techniques like hand washing and whatnot. Because in my estimation, until we're through this, which could be 6 months to a year by the time all of the vaccines roll out and by the time people either have it or get the vaccine, and we get a sizable proportion of the population with herd immunity, I think we still need to be on our guard. Why? Because this disease in 40% of the cases is asymptomatic, and those people are potentially carriers. And so don't take it for granted, you guys, because you may have a loved one who is vulnerable. In my case, my dear 88-year-old mother-in-law lives with us, and I wouldn't compromise her for a second. And so we've been very strict. And, in this case, the boys are in quarantine, in virtual school, and my wife and I take huge precautions when we shoot or we do anything. And in her case, she's had to have 5 COVID tests before she shot or did other things. And, on a repeated basis before she enters into a quarantine like bubble, if you will. And in my case, I've been wearing a mask, hand washing, and doing all that. So the answer is simple: benefit to risk. Whenever this gets there, I would say the AstraZeneca Oxford vaccine may be approved and to us by the middle of January, because the results won't be back until the end of December. And then the approval process from the FDA and others will be there. And then they'll have to upregulate. The good news is there are local creators. And just to answer your question, a vaccine is deemed successful when 50% of the people are protected from the disease. And in this case, this is a revolution, you guys. When you're seeing 72 or 95% of these patients, 72 in the case of the Oxford vaccine, all combined, and 95% in the case of the Pfizer and the Moderna vaccine, that's a revolution in vaccine technology. So the one thing I'm going to say in the silver lining is that we've advanced how we do immunology, how we do this with CRISPR, with DNA techniques, with other things. And, I said this before the talk, but it's like going to the moon. You're going to get a huge number of discoveries on the way, like ballpoint pens and frozen ice cream and other such niceties, but also, hard-earned stuff, which will benefit society. So there are some silver linings in that we're going to improve. The other thing is telemedicine went up by droves. And I think we also galvanized our ability to look at healthcare critically and look at the populations at risk in India as well as worldwide. And we've all suffered, in one way or another. Even if you've not had the disease, we've all suffered. But we will get through this together.
No, I think that's probably one of the most comprehensive and insightful, discussions on the vaccine and what role it has to play in the epidemic. And like Dr. Nene was saying, I think the critical thing is to wait and watch and never to actually let down your guard, because there is not just one kind of pandemic. There are multiple other health issues, and we need to be addressing all of them together and be cognizant of not just our vulnerability, but the vulnerabilities of those around us. Remember, a mask doesn't just protect you, it protects others as well. On that note, I want to thank you, Dr. Nene. I know you have a grueling schedule. Thank you so much for making time to be with us today and giving us all these insights. And we will see you all next week with another expert on critical conversations. Thank you.